Hey everyone, welcome to the Optispan podcast. So it feels like it's been a while since I've done a dedicated episode to my favorite molecule, which is of course rapamycin, or as those of you in the know refer to it, vitamin R. And this is a topic that recently came across my radar related to the effects of rapamycin on brain function. I get a lot of people asking me about rapamycin for people who carry the APOE4 genetic variant. And I've just recently started my current course of rapamycin, so the timing is good. So I started a cycle of rapamycin. I'm doing 8 milligrams once a week, started at the beginning of January. Again, my intention is to do a 12-week course, and that's after taking rapamycin from January to June last year in 2024, and then not being on rapamycin since July 1st of last year. So I'll say once again, it's interesting. Since I've started rapamycin about 4 weeks ago now, I've definitely perceived a pretty dramatic reduction in joint pain in like my wrist and my elbows when I'm lifting weights. It seems like a pretty significant reduction in lower back pain. I have no idea. It could be placebo effect, could be a real effect. I suspect that it is related to the anti-inflammatory effects of rapamycin, but of course, we don't know because we don't have the dedicated clinical trials at this point. So in any case, my perception has been that within a few weeks, which is typically what I experience, some of the joint pain and things like that tend to accumulate when I'm not taking rapamycin go away pretty rapidly. And that's been the case this time around. Again, if anything interesting pops up, I will be sure to let you know. Okay, so in today's episode, I want to do a little bit of a deeper dive on this question of whether or not people who carry the APOE4 allele should be taking rapamycin. And I'll give you my thoughts on this question. As always, I'm not an MD. This is not medical advice. It's just the opinion of someone who's done a lot of research on rapamycin. And by research, I mean actual real laboratory research, not prompting ChatGPT or DeepSeek to tell me about rapamycin. So I do have some experience in this space for whatever you think that's worth. So for those of you who just want to jump to the punchline, the answer, in my opinion, is yes. People who have the APOE4 allele should, at a minimum, consider taking rapamycin and discuss that with your medical professional. I think the current evidence for risk reward in this context, if you have 1 or 2 copies of the APOE4 allele, is strongly favoring trying rapamycin as a preventative. Again, not my opinion, not medical advice. And of course, if you do take rapamycin for this or any other reason, do it under the care of a medical professional. Do not order it from a laboratory as a powder and try to put it on your cereal or any other way of taking rapamycin. Okay, so now I'll explain why I think, especially if you are at high risk of dementia due to carrying an APOE4 allele, you might want to strongly consider rapamycin. So let's take a step back. What is APOE? So APOE is a gene, and it codes for a protein called apolipoprotein E. So apolipoprotein E is a version of something called an apolipoprotein. And apolipoproteins are best known as proteins that help transport lipids or fats throughout our bodies. So the exact definition of an apolipoprotein is a protein that binds to lipids, and then when the apolipoprotein binds to lipids, it forms a lipoprotein or a lipid protein complex. Okay, so apolipoprotein, fat, they come together, lipoprotein. Okay, that's all those words mean. So why do our bodies do this in the first place? It seems really complicated. Our bodies do this because fats are not soluble in aqueous solution, and our blood is an aqueous solution, meaning it's mostly water. So we need the proteins to help get the fat and keep the fat into solution so that it can transport around our body, not form big globs of gunk clogging up our arteries. So we wrap them in proteins, transport the fats around our bodies, and this happens both inside of cells and also outside of cells, like in our circulatory system. So that's why we have these apolipoproteins. And APOE is just one version of an apolipoprotein. So again, the best known lipoproteins, again, lipoprotein is the apolipoproteins and fats glommed together. So the best known lipoproteins are HDL and LDL, high density lipoprotein and low density lipoprotein, or more colloquially known as good cholesterol and bad cholesterol. And so HDL and LDL carry cholesterol around our bodies. HDL and LDL particles are made up of cholesterol and several different apolipoproteins. So just to give you guys a little bit of more nuance, HDL consists of apolipoprotein A1, apolipoprotein A2, sometimes apolipoprotein C, and apolipoprotein E. Okay, remember apolipoprotein E is the protein that is made from the APOE gene. And that all depends on the specific subclass of HDL. LDL is kind of similar, but it has different apolipoproteins in different LDL particles. Again, apolipoprotein E is not the primary apolipoprotein found in LDL, but some LDL particles do contain apolipoprotein E. So apolipoprotein E is a component of these lipoproteins that transport cholesterol and other fats throughout our bodies. Okay, so again, just to start from the beginning, APOE, that's what you're mostly going to hear of when you hear about APOE and its risk in Alzheimer's disease, is the gene that codes for apolipoprotein E. Apolipoprotein E is a protein that is found in a variety of lipoproteins, including some HDL and LDL subtypes. Okay, so APOE, going back to the gene, has three primary variants. So every gene in our body has different variants in different people, and those variants are different from each other in that they have specific changes to the DNA, the nucleotides in the gene that determine the structure of that protein. So there are three primary variants of APOE gene: epsilon 2, epsilon 3, or epsilon 4, or E2, E3, and E4. That's where the APOE4 comes from. Okay, so that's a version of the APOE gene. And again, remember, the APOE gene codes for apolipoprotein E. So these different versions of the gene, E2, E3, E4, create slightly different versions of the protein. And of course, the protein is the machine that actually does the work in our bodies. So these are like slightly different versions of the apolipoprotein E machine. Okay, so E2, E3, E4 create different versions of the machine. And this is kind of an oversimplification, but it's not way off. You can kind of think of E2 as the premier version, the best version that works the best. E3 is the normal version that most people have. And E4 is the worst version, the version that doesn't quite work as well. That's again an oversimplification, but probably good enough for now. Again, this is not a perfect analogy, but I think it works okay. So for those of you who aren't super familiar with genetics, kind of think of it like different quality of parts or motor oils for your gas-powered car. So APOE2 would be like the really high quality premier motor oil that functions better under pretty much every driving condition you could imagine. E3 would be like the medium quality motor oil that it kind of gets the job done, but it's not as good as E2, doesn't last quite as long, maybe not quite as good under extreme driving conditions. And E4 would be like the really, really lowest budget motor oil you could possibly buy, doesn't last very long, doesn't work as well, and it especially becomes problematic under harsh driving conditions or particularly aggressive driving conditions, challenging environmental conditions, okay? So that's a way to think about APOE2, APOE3, and APOE4. Okay, so that's almost all you need now, except there's one more thing you have to keep in mind. For most of the genes in our body, including APOE, we actually have two copies of those genes, okay? We get one from our mother and one from our father, and that's what comes together to make us unique individuals. So for every gene, pretty much, other than on the sex chromosomes in some cases, you have two copies, okay? So for APOE, we all have two copies of APOE, and you can have different versions of the E2, E3, and E4 alleles. So there are really 6 possibilities for each person. You could have two copies of the good version, E2, E2. You could have E2 and E3, so one good, one sort of medium. You could have 2 copies of E3, that's E3, E3. That's the most common genotype for APOE. That's the most common combination out there. You could have one E2 and one E4, so one very, very good version, one bad version. You could have E3, E4, one normal, one bad, and you can have 2 copies of E4, two of the lower quality motor oil in this analogy, okay? Hopefully that makes sense. So APOE gene codes for apolipoprotein E, which helps transport fat around the body. There are 3 common versions of the APOE gene, which make slightly different versions of the apolipoprotein E. Those are E2, E3, E4. E2 makes the best version of apolipoprotein E. E3 makes the normal version, and E4 makes the less functional version, okay? A little bit of an oversimplification, but pretty close. Now, if we look at those 6 categories, we can kind of put them in a table and summarize, like, what do we know about the different genotypes, the different variants, versions of those 2 alleles that different people have. And if we rank them, again, oversimplified from best to worst, E2 is the best. That's got the best lipid metabolism, lowest risk for Alzheimer's disease. So that tends to be associated with the best health outcomes. The second best is E2, E3. The most common version is E3, E3. Slightly less preferred would be E2, E4. So you've got one good copy and one of the bad copies. So a somewhat increased risk of Alzheimer's disease compared to E2, E3. E3, E4. So that's the most common for people who have E4. You're going to be a carrier of one copy. You're going to be E3, E4 in the most common cases of carriers of E4, and you have an increased risk for cardiovascular disease and Alzheimer's disease. Fortunately, in these people, lifestyle is really, really effective at reducing that risk. So if you live a very clean lifestyle, healthy diet, exercise, good sleep quality, avoid alcohol, you can pretty much mitigate that increased risk of Alzheimer's disease and cardiovascular disease if you're an E3, E4. E4, E4 would be 2 copies of the worst allele. And again, here, the Alzheimer's risk goes up quite dramatically. Cardiovascular disease risk goes up quite dramatically, about 12 to 15-fold for Alzheimer's disease. Higher LDL, lower HDL, a lot of inflammation is pretty typical. Again here, the good news is lifestyle can have a big impact. But in most cases, in an E4, E4 homozygote, lifestyle isn't going to get you all the way back to the risk profile of an E3, E3 person. Okay, so those are sort of the possibilities that are out there. If you don't know your APOE genotype, I personally think it's a good idea to know. There are, as I've already alluded to, things you can do in terms of lifestyle and potentially things you can do in terms of pharmacological interventions like rapamycin. Okay, so again, key considerations, E2, E2, that's the best chance for overall longevity and health. E2, E3, protection against cardiovascular and neurodegenerative disease. E3, E3, the normal risk factors. E2, E4, mixed, little bit higher risk of Alzheimer's disease, but not too bad. E3, E4, about a 3 to 4-fold increased risk of Alzheimer's disease. E4, E4, 12 to 15-fold increased risk. All of these are modifiable by lifestyle. Okay, so why should you care? Again, unfortunately, at least for now, you can't change your motor oil, right? You're born with it. But if you do know your APOE genotype, you can assess your relative risk of cardiovascular disease and particularly Alzheimer's disease and take preventative action. Again, for now, that preventative action is mostly related to lifestyle, but it's really even more important for people who have 1 or 2 copies of E4. And you might want to consider less proven things like rapamycin, particularly as the risk-reward profile shifts towards a much potentially greater reward if rapamycin is protective when you get to E3, E4, and E4, E4. So that's kind of the risk analysis way of thinking about, why would we particularly potentially recommend rapamycin for people who have 1 or 2 copies of the E4 allele, because the risk of developing Alzheimer's disease and cardiovascular disease is higher. So the potential benefits of rapamycin are greater in those individuals compared to, say, E2 carriers. So now let's dive into the case for why rapamycin might be beneficial, particularly for people who carry the APOE4 allele. And there are really 2 flavors of evidence here. Most of it is what we would call preclinical, meaning this comes from studies in laboratory animals, and most of those are going to be in mice and rats. And so there are numerous rodent models of Alzheimer's disease and normative aging where rapamycin has been shown to delay, prevent, or reverse pathology, so things like plaques and tangles, molecular changes associated with that pathology, and functional outcomes, how well the brain is functioning, so memory, learning, things like that. In all 3 of those domains, in these rodent models of Alzheimer's disease and normative aging, rapamycin has been shown to at least delay the progression, and in some cases actually reverse the progression in aged animals. And several years ago now, Veronica Galvin and myself wrote an article in Science Translational Medicine titled Rapamycin and Alzheimer's Disease, Time for a Clinical Trial. We strongly advocated that it was overdue in 2019 when this article was published for randomized, double-blind, placebo-controlled clinical trials to be done to determine whether or not rapamycin can delay, potentially halt the progression of Alzheimer's disease and other related dementias. That still hasn't happened. That's very frustrating. But it's based on this very, very large body of literature, which was there in 2019 and has continued to grow since then. And so now we're starting to get some human data. And there was very recently this paper that came out. It's a very small study, but I thought it was very interesting, starting now to provide a case that some of these changes that we see in rodents that we would consider beneficial may also happen in people taking rapamycin. So this is a study that was published on January 9th, so just a couple of weeks ago, titled Short-Term Sirolimus Treatment Restores Hippocampus and Caudate Volumes and Global Cerebral Blood Flow in Asymptomatic APOE4 Carriers compared with non-carriers. And we'll get into the data. There's not a lot of it, unfortunately, but let me just take you through that title. So short-term sirolimus. Sirolimus is rapamycin, exactly the same molecule, has 2 different names. I know it's confusing and complicated. That's just the way it is. Okay, so you could just put rapamycin in there. Short-term rapamycin treatment restores hippocampus and caudate volume. So those are regions of the brain that are known to shrink during Alzheimer's disease. And you can actually see premature volume losses in people who have the APOE4 allele, if we look at age-matched individuals. So what this is saying is that in APOE4 carriers, people who have 1 copy of APOE4 and then 1 copy of APOE3, short-term rapamycin treatment is actually restoring these brain volumes in people who may have lost brain volume, and it's improving cerebral blood flow. In other words, blood flow to the brain, okay? Specifically in people who are carriers of APOE4 compared to people who are non-carriers, okay? So we'll get into what they actually showed, but that's essentially what that title is claiming. Okay, so the article's really short, so I'm just gonna read the whole thing and then I'll comment as we go, and then we'll just take a quick look at the data. Okay, so the background starts, apolipoprotein E4 allele, APOE4, is the strongest genetic risk factor for late onset Alzheimer's disease. Compared with non-carriers, cognitively normal APOE4 individuals have shown brain atrophy and lower cerebral blood flow decades before AD pathological and clinical symptoms appear. Okay, so all that's saying is people who have 1 copy of APOE4 show brain atrophy, so changes, negative changes in the volume of the brain, and less blood flow to the brain decades before people who don't have the APOE4 allele. So premature onset of these conditions. The goal of this study is to determine if using sirolimus, rapamycin, an FDA-approved mTOR inhibitor, could restore brain volumes in structures related to cognitive functions and global cerebral blood flow for asymptomatic APOE4 carriers compared with non-carriers. Okay, so again, they're going to look at the structures in two regions of the brain and cerebral blood flow, and they're going to compare the effects of rapamycin in people who have one copy of APOE4 to people who have 0 copies of APOE4. Okay, so the methods, I'm not going to take you through the whole thing, but I think there's a couple of important pieces here. They used low-dose rapamycin at 1 milligram per day. So that is lower than the organ transplant doses, but it was given daily. I know many of you are familiar with the idea that off-label use of rapamycin now is typically weekly. There were only 5 people in the study, so 3 of them were APOE4 carriers, but they're all cognitively normal. 2 of them were non-carriers, so those are APOE3, E3 individuals. All 45 to 65 years old, none of them had dementia or mild cognitive impairment. So this is the real limitation to this study, of course. Only 5 people, 3 in one group, 2 in the other group. In the APOE4 carrier group, 2 were female, 1 was male. So tiny study. We have to be careful, obviously, not to over-extrapolate the conclusions. The rest of the methods are just that they used MRI to look at brain volumes and the software that they used to do the analysis. So let's dive into the results, because this is where the real meat of the study is. So it says APOE4 carriers had significantly increased caudate and hippocampal volumes after 4 weeks of sirolimus treatment. Okay, so what this is saying is when you do an MRI at baseline and at 4 weeks, in the 3 APOE4 carriers, there was an increase in volume in both the caudate and the hippocampus of the brain, and an improvement in global cerebral blood flow. And 4 weeks is interesting because that's not a very long time, but those of us who are in the field, I think, all recognize that's long enough where there's enough evidence now that you see benefits of rapamycin in that short of a time frame. So that's pretty interesting. And again, remember the dose here is only 1 milligram a day. So the section goes on. The quantitative data is shown in table 1. It also shows that APOE4 carriers had lower hippocampal volume and cerebral blood flow at baseline compared with the APOE3 participants. And that's to be expected, but again, interesting and reassuring that they were able to detect that in this study. The people who had one bad copy of APOE started worse, because these are all people who are over 45, than the people who did not have one copy of APOE. So lower brain volume, lower cerebral blood flow. Sirolimus tends to restore the values to closer to those of the non-carriers. In other words, it's taking the lower starting values and bringing the non-carriers back up close to the carriers. No side effects were observed, and no changes in blood glucose or hemoglobin A1C levels were found in the participants. Again, there's some ideas out there that rapamycin, even at the off-label lower doses, may lead to changes in blood glucose or changes in lipids that are suboptimal. I don't know of a lot of data to support that. They didn't see that, at least with respect to glucose and A1C in this study. Again, it was only 4 weeks. Okay, so their conclusion: we show that short-term sirolimus treatment can effectively restore brain volumes and global cerebral blood flow for asymptomatic APOE4 carriers, specifically in the caudate and hippocampus, which play many roles integral in normal cognitive functioning, including memory, learning, and emotional regulation, has considerable atrophy in Alzheimer's disease. The findings imply that sirolimus may be useful and effective to mitigate or prevent Alzheimer's disease developments for asymptomatic APOE4 carriers. Okay, so that's a pretty clear, I think, statement of their findings. I generally agree with this. Again, given the caveats, it's a relatively small study, and it wasn't, randomized, double-blind, placebo-controlled. The data, I think, are pretty convincing and interesting. So let's look at the data. So in figure 1A, this is showing the volume of the caudate and the hippocampus, again, measured by MRI. It's pretty clear there is a statistically significant increase in brain volume in the APOE4 carriers in both regions of the brain, going from baseline to 4 weeks later after treatment with rapamycin. I wish they kind of showed the individual trajectories. In other words, is it always the person who started the lowest who ends up the lowest? Did every single person improve? That's a little bit unclear from the way the data is presented, but overall, there was a statistically significant improvement in brain volume in both regions, and also in the perfusion-weighted global cerebral blood flow. So they're just looking at blood flow to the brain. Again, pretty clear, statistically significant improvement in 4 weeks in the people, the APOE4 carriers who got rapamycin. We can also look at the table. It's interesting here, there was not a statistically significant change in the APOE3 homozygotes. So the people who have the most common genotype, 2 copies of the E3 allele, the normal people, at least for APOE, there was no significant change with rapamycin. It's a little bit, again, there's only 2 people, so, it's hard to draw too many conclusions. This might suggest that rapamycin is more effective, at least at changing brain volume and cerebral blood flow in people who are APOE4 carriers, more speculatively in people who have some perturbation already, even maybe going into the range of mild cognitive impairment. So in people where there's been a decline, you can see the benefit. This might suggest, it's very weak, but it might suggest in people who haven't yet shown a decline, you're not going to see any benefit from rapamycin, at least for these metrics. Super interesting, right? On its own, suggestive, but certainly not definitive. But I think one thing we can do to ask ourselves, how likely is this to be real, is say, does this match what has been seen in other studies, in other animals? And the answer is really clear and I think very definitive. Yes, there's a ton of rodent studies that this matches perfectly with. So I'm not going to take you through all of them, but there's a few I think that are worth highlighting. So one is a study from Arlen Richardson's group titled Rapamycin Restores Brain Vasculature, Metabolism, and Blood-Brain Barrier in an Inflammaging model. This was published a couple of years ago in Geroscience. This was a rat, not mouse, a rat model of inflammation. And the way they caused inflammation is they used this molecule called LPS, which is a known inflammatory molecule, to cause high levels of systemic inflammation. And in this case, they treated with rapamycin in the food. This is called eRapa. It's the same formulation used by the Interventions Testing Program, for those of you, again, who are rapamycin aficionados. And they treated for 6 weeks. And in that 6-week period, so they used this inflammation model to cause a defect in cerebral blood flow and blood-brain barrier function. And in that 6 weeks treatment period, they were able to show that rapamycin rescued that defect. It restored cerebral blood flow and blood-brain barrier function back to close to normal levels. Okay, so that's pretty interesting. It's an artificial model, but it's rats. Okay, so then let's move to mice, because there's a whole, again, large body of literature in mice. And I want to start with one of the first studies that looked at the impact of rapamycin on cerebral blood flow in mice modeled to get Alzheimer's disease. So this is work from Veronica Galvin's lab, published back in 2013. The title of the paper is Chronic Rapamycin Restores Brain Vascular Integrity and Function through Nitric Oxide Synthase Activation and Improves Memory in Symptomatic Mice Modeling Alzheimer's Disease. So these mice are genetically engineered to get dementia, and it has features associated with Alzheimer's disease. Lots of people don't like mouse models of Alzheimer's disease, good reasons not to like any of the mouse models of Alzheimer's disease, at least as perfect models of Alzheimer's disease. But they do recapitulate features of the disease, and there's an age onset progression in these mouse models. And what Veronica's lab showed in this case was that chronic treatment, so long-term treatment with rapamycin in these mice, could prevent loss of vascular integrity in the brain. The specific mechanism here, we don't really need to worry about. They said it was through nitric oxide synthase activation, but it could prevent the loss of vascular integrity, so integrity of the blood vessels in the brain, and more importantly, actually improve memory, even in mice that are already symptomatic, right? So they've already starting to show memory declines. You start treating them with rapamycin, you actually get a boost. That's super important, I think, if we're thinking about moving this into people, and is relevant to the human study that I just talked about, because those people already showed declines in hippocampal volume, caudate volume, and cerebral blood flow that rapamycin could restore. So even after declines have started, rapamycin looks like it may have some benefits in both people and mice. Okay. And so after this paper, Veronica's lab went on to show that rapamycin could improve cerebrovascular function, synaptic function, and cognitive function during normal aging. In other words, what they showed in that 2013 paper wasn't specific to the Alzheimer's disease models. It was also true in normative aging mice, okay? Which is, again, I think really interesting as we start to think about potential translation to humans, and also I think addresses some of the concerns about if all of the data is in Alzheimer's disease models in mice and none of those models are very good, there's concerns about that data. But if you see the same thing in normally aging mice that haven't been engineered to get Alzheimer's disease, starts to give more confidence that this is probably a real effect. And then later on, Stacy Hussong's lab, in a paper titled Rapamycin Restores Peripheral Blood Flow in Aged Mice and in Mouse Models of Atherosclerosis and Alzheimer's Disease, showed that not only was rapamycin improving cerebrovascular blood flow, it's also improving peripheral blood flow out of the brain. They did this in mouse models of atherosclerosis, mouse models of Alzheimer's disease, and also normally aging mice. So it's not specific to any particular mouse model. And then the last paper of relevance here, because we started from the APOE4 angle, is again work from Arlen Richardson's group. And the title of that paper is Rapamycin Rescues Vascular, Metabolic, and Learning Deficits in Apolipoprotein E4 transgenic mice with presymptomatic Alzheimer's disease. So what they did in this case was they took the human APOE4 variant, put it into mice. Those mice developed symptoms of Alzheimer's disease, and they showed in that context, rapamycin could rescue the vascular part, so the cerebral blood flow part, metabolic derangements, and functionally learning deficits. So again, in my view, this is a really compelling body of literature that, unfortunately has been largely ignored by the clinical world working on Alzheimer's disease. But it all, I think, is consistent with this newer study, even though there are issues with the size of that study, suggesting that in people, in just 4 weeks, rapamycin could potentially have an impact. Now let's ask the question, let's just accept for a minute that the results from this new study are real and they'll be reproducible. We don't know that yet. Let's accept that that's the case. We can ask the question, what's the impact of rapamycin here compared to what we think the impact of other lifestyle factors might be on volume changes in the same regions of the brain? It's not apples to apples. I'm not pretending that it is, but we'll do the best we can. So in this study, there was a 14% increase in hippocampal volume in 4 weeks from 1 milligram per day of rapamycin. Prior studies have pretty consistently suggested that exercise can lead to about a 2% increase over a period of about 1 to 2 years. And the MEND program, which is a lifestyle-based program, a lot of dietary changes, but some other lifestyle factors as well. This is Dale Bredesen and colleagues have developed this program, which stands for Metabolic Enhancement for Neurodegeneration. This is really primarily a lifestyle-based program, so nutritional changes, exercise. There's some kind of dubious supplements added in there, at least in my view. Some of them are dubious. That showed about a 10% increase in hippocampal volume over 10 months. So again, don't want to draw too many conclusions other than to say the efficacy size in this study is pretty comparable to the efficacy size of some of these lifestyle approaches that are in the literature. And so overall, I would characterize this as pretty suggestive at a minimum that rapamycin at 1 milligram per day for 4 weeks could have benefits for APOE4 carriers in terms of both brain volume changes and cerebral blood flow changes. We can't really, I don't think, conclude anything about the impact of rapamycin in non-carriers from this study other than they did not see any changes. Obviously, we need larger, longer-term studies. Again, in my view, obviously, it's ridiculous that this hasn't happened yet. Maybe now it will. We could do this easily right now. Like this study could be replicated in a couple hundred people, kind of trivial to do, should be done right away. I'd personally like to see the dosing explored a little bit more. I'd like to see a comparison to once weekly dosing, which is what most people are doing. But this fits really, really well with what we know in mice and rats about the effects of rapamycin on cerebral blood flow, changes in brain volume, and Alzheimer's disease progression in those models, and also changes in brain function and cognitive function during normative aging. So my gut feeling is this is a real result. I also suspect that better outcomes could be observed by exploring dosing and duration. And that's why I feel pretty comfortable, in my opinion, that, for my own friends and family who are APOE4 carriers, I always tell them, yeah, you really ought to take a close look at trying rapamycin. We don't know for sure, but I think the risk reward is leaning pretty far towards reward in this particular case. So what about people who are not E4 carriers? I'm E3, so I've got the generic genotype. And so I think here it's kind of interesting to note that hippocampal brain volume seems to decrease by about 1% per year just during normative aging, okay? And it can be faster, 2 to 5% per year in individuals with mild cognitive impairment. Also, we're saying, APOE4 carriers, it's kind of obvious, but worth stating explicitly, aren't the only people who go on to develop mild cognitive impairment and Alzheimer's disease. So there are other reasons you could get Alzheimer's disease for sure. So could rapamycin be beneficial in E3 carriers? Again, I think probably so. It may be the case that you're not going to see benefits above baseline, right? So it's only once you start to see these deficits occur that you're going to be able to detect benefits from rapamycin. Again, we would obviously need more studies to know that. But in normally aging mice, and wild-type mice don't have the human APOE4 gene, their rapamycin seems beneficial for both cerebral blood flow and brain volume, and of course a bunch of other healthspan benefits, and of course lifespan benefits. So I think it's probably the case that even in E3 carriers, there's a likelihood that rapamycin could have benefits, but again, you might not see it till you get into the deficit range. And then finally, I just want to end with a little bit of speculation. I've personally found it interesting for several years that traumatic brain injury, particularly repeated traumatic brain injury, causes many similar changes, both in terms of brain volume and molecular phenotypes, as normative brain aging and what's seen in people with mild cognitive impairment on their way to dementia. And I've been suggesting for a while now that rapamycin might be really interesting to study in the context of these effects of traumatic brain injury on brain morphology, brain atrophy, cerebral blood flow, blood-brain barrier function, and of course, cognitive function, brain function. Again, super easy to test, trivial, and as far as I know, nobody has really done this in any sort of systematic way in people. So I think it would be super interesting to get a collection of people who have suffered from traumatic brain injury. Professional athletes would be one, I think, really interesting group. Combat veterans would be another really interesting group. Give them MRIs, give half of them rapamycin, half placebo, look and see what the outcome is. Like that's easy. So I think that would be a super interesting study. This is total speculation. I speculate that rapamycin treatment right after a traumatic brain injury might be protective. There's a lot of, I think, kind of low-hanging fruit that could be explored here that I'd like to see people start to take a look at. Okay, and then finally, if any of you are interested, I did an episode on whole body MRI. where I'd refer you to that episode if you're interested in that topic. But as part of that, I did get a brain MRI, uploaded it to a BrainKey, and got measurements of the different brain volumes for different regions of my brain. So it turns out for the caudate nucleus, I'm in the 93rd percentile. I feel pretty good about that. For the hippocampus, I'm in the 79th percentile. Feel okay about that. Size isn't everything, but size is something when it comes to brain volume. Of course, what we're really interested in is brain function. I'm showing this, though, just to show you how really trivial it is to get reasonably quantitative measures of brain volume. This can be done, through direct-to-consumer whole-body MRI. If you had even higher resolution brain imaging, I'm sure you could get much better quantitative information on the different brain regions. So when I got my whole-body MRI, I was not taking rapamycin. Unfortunately, I don't have any prior images to see, what the before and after looked like. But going forward, I will now have this baseline, so I'll be able to see how my brain volume changes going forward. So just to wrap up, it's early, but the early data is certainly consistent with the idea that rapamycin may increase brain volume, at least in specific regions of the brain that are affected in dementia patients, and at least in people who have the APOE4 variant, so the bad allele of APOE. Matches a very large body of literature in rodents. Of course, we need more studies looking at efficacy, size, and different dosing strategies. But my opinion is it makes sense if you're an APOE4 carrier or APOE4 homozygote to at least discuss off-label use of rapamycin with your doctor and potentially to monitor efficacy with the use of brain MRI. All right, so that was longer than I thought it would be. Hopefully some of you stuck with me through the whole thing. And as always, if you've got any questions or comments, please leave them below. If you're not yet a subscriber, I'd really appreciate if you hit that subscribe button. You should also check out our newsletter. If you're not yet a newsletter subscriber, I try to put some interesting stuff in there that you're not going to see on the podcast channel. And as always, I hope to see you again on the Optispan podcast.